Good afternoon, and thank you for joining us. My name is Rhea Farberman. I'm the Director of Strategic Communications and Policy Research at Trust for America's Health, also known as TFAH, TFAH. TFAH is a nonprofit, nonpartisan public health policy research and advocacy organization. Our mission is to promote those policies that will support optimal health in every community. This afternoon's briefing will focus on a report we released this morning. It's our 9th annual report, the 2025 version of Pain in the Nation, the Epidemics of Alcohol, Drug, and Suicide Deaths. The report tracks the data on substance misuse and suicide deaths nationally and at the state level, and for population groups. It also includes a number of recommendations about how to sustain the recent progress that's been made in reducing the rates of these deaths, how to ensure that this progress be more universally enjoyed across all communities, experienced across all communities, and raises concerns about the ways in which that proposed and current cuts to the federal health workforce and federal health unit reorganizations and RIFs could put these improvements, this progress in jeopardy. We'll hear from 3 panelists during the first half of the program, and then we'll spend the second half of the program to answer your questions. If you submitted a question before we began this afternoon, thank you. We'll get to those questions. We also invite you to submit questions during the session. You can do so by using the Q&A tool on the platform. So before we start, I've invited you to submit questions, so that's fine. We'll now move to introduce our panelists. Our first panelist is Dr. Nadine Gracia. She is the President and CEO of Trust for America's Health. She's a national leader in health policy, public health, and health equity issues. During the Obama administration, Dr. Gracia was the Deputy Assistant Secretary for Minority Health and the Director of the Office of Minority Health at HHS. Dr. Gracia, welcome, and please start your remarks.
Thank you, Rhea, and good afternoon, and thank you all for your interest in our report. As Rhea noted today, Trust for America's Health is releasing our 9th annual report, Pain in the Nation, the Epidemics of Alcohol, Drug, and Suicide Deaths. We produce these reports to track trends in these epidemics, to guide policymakers, and to help the public understand that with evidence-based policies and investments, these tragic deaths are preventable. Our report is more than solely presenting the data. We examine the causes behind these trends and what we can do to prevent deaths and suffering. Next slide, please. This year's 2025 report has promising news. Investments in substance use disorder and suicide prevention are saving lives. The combined number of deaths from alcohol, drugs, and suicide in the United States declined in 2023, which is the last year of complete data, for the 2nd straight year, after 2 decades in which such deaths were increasing at an alarming pace. And recently released provisional data also show major declines from drug overdose deaths in 2024. The new data highlight the value of investment in mental health and substance use prevention programs, including access to treatment and overdose reversal medications, data and research systems, crisis intervention services, and conditions that foster health and well-being. Next slide, please. Now, despite this promising news, over 200,000 Americans died due to alcohol, drug, or suicide in 2023. This is twice the rate of such deaths 20 years ago. This loss of life is tragic, and these rates are unacceptably high. We're also still seeing disparities. Not all populations experience the same improvements. And so going forward, we need to ensure that every community has the opportunity for health and well-being. We are starting to see progress, and the challenge now is to ensure that this progress is sustained and experienced in all communities. But this progress is in serious jeopardy due to recent and proposed cuts in federal funding and workforce at the Centers for Disease Control and Prevention, or CDC, and the Substance Abuse and Mental Health Services Administration, or SAMHSA. Next slide, please. Now, when we look specifically at drug overdose deaths, CDC's provisional 2024 data show a noteworthy 27% reduction in overdose deaths nationally. 7 states, including Louisiana, Michigan, New Hampshire, Ohio, Virginia, West Virginia, and Wisconsin, as well as Washington, D.C., have predicted declines of 35% or more in overdose deaths for 2024. Now, among the tools that led to these reductions in overdose deaths are improved data systems that allow local officials to track drug misuse trends and direct resources where they're needed most, as well as the availability of overdose reversal medications like naloxone. TFAH's report analyzed 2023 data, and we found that the largest decreases in deaths from drug overdose were among white people. Black people and Native Hawaiian people experienced an increase in overdose deaths, and other groups, including American Indian, Alaska Native people, had relatively flat rates compared to 2022. Next slide, please. Now, in terms of alcohol-induced deaths, the data also show a 7% decline in alcohol-induced deaths in 2023. This was the second year in a row of a decline after 2 decades of increases. Next slide. Regarding suicide, the overall rate of deaths from suicide was relatively unchanged in 2023, with highest rates among American Indian and Alaska Native people, males, and older adults over the age of 75. And what we are seeing is that firearms are related to more suicides than any other means. Next slide, please. What these data show is that investment in mental health, primary prevention, and substance misuse prevention programs can save lives. It is vitally important that we build on this progress. And it's important to understand that 80% of CDC's domestic budget goes to states, cities, tribes, nonprofits, and other entities. Across the country, this federal funding is working to address local communities' specific substance use and suicide prevention needs. Locally led primary prevention programs are critical to addressing substance misuse and suicide deaths, but they rely on federal funding. So the funding cutbacks, the elimination of successful programs, and the significant staff reductions at CDC and SAMHSA will translate into the loss of interventions that support critical prevention activities and provide trends data, as well as expertise and technical assistance to localities. For example, the CDC Injury Center is proposed for elimination in the fiscal year 2026 budget and the HHS restructuring plan. The Injury Center helps health departments implement community-level best practices and use data to tailor and direct prevention programs where they are most needed. Furthermore, the data systems supported by CDC funding help track overdose and near overdose patterns. Then health departments can work with emergency departments and first responders to be able to deploy overdose reversal medications where they're needed. Localities also depend on CDC laboratories and expertise for detecting new substances in the drug supply and deploying proven prevention practices. The Injury Center's distinct functions also inform and complement other federal agencies' programs, such as SAMHSA, to enhance overall overdose and suicide prevention efforts. However, the administration has proposed eliminating the CDC Injury Center, as well as cutting an additional $1 billion in SAMHSA funding and consolidating what remains from both entities into a new agency. Now, you're going to hear more about the importance of the work of the CDC Injury Center from one of our speakers today, Sharon Gilmartin of the Safe States Alliance. Next slide, please. Now, our policy recommendations in this year's Pain in the Nation report address 3 main areas. 1, protecting investments in prevention. 2, reducing overdose and suicide risks. And 3, transforming the mental health and substance use prevention systems. We need to protect investments in preventing substance misuse and suicide and restore the workforce that's dedicated to these efforts. We need to support programs that reduce adverse childhood experiences and support substance use prevention, resiliency, and mental health in schools. We need to ensure that everyone has access to mental health and substance use treatment programs that they may need, and that these programs address non-medical and health-related needs such as housing and food security. And we need to properly deploy overdose reversal medication and strengthen the continuum of crisis services. Next slide, please. So two takeaways that I'll leave you with. One is focusing on the underlying drivers of substance use and suicide through early intervention and prevention policies and programs will save lives. And secondly, the current and proposed cuts to the federal workforce, budgets, and prevention programs will actually cost lives. Thank you, and I'm going to turn it back to my colleague, Rhea Farberman.
Thank you, Dr. Gracia. Our next speaker is Sharon Gill-Martin, the Executive Director of the Safe States Alliance. Sharon, please.
Thank you. Good afternoon. Thank you for joining us today. And thank you to Dr. Gracia for those excellent opening remarks. I'll start here. The numbers in this year's Pain in the Nation report tell a really powerful story. It's a story of both progress and risk. We are seeing hopeful signs in the national fight against drug overdoses, but we are simultaneously being reminded of just how fragile our progress is when the systems that support it are under threat. As Dr. Gracia mentioned, according to the latest data released last week, 2 weeks ago actually, from CDC's National Vital Statistics System, there has been a remarkable 26.9% decrease in predicted drug overdose deaths nationwide from 2023 to 2024. That is an average of more than 81 lives every single day. But that's not just a statistic. It's a testament to the tireless work of prevention specialists, local health departments, harm reduction organizations, and the critical coordination led by CDC's National Center for Injury Prevention and Control, known to friends, as Dr. Gracia mentioned, as the CDC Injury Center. But despite this progress, we're still losing over 80,000 lives a year to overdoses, nearly 50,000 more to suicide, and alcohol-related deaths continue to climb. We all know these aren't just numbers. They're family members, they're friends, they're coworkers, they're classmates, and each one of them a loss with ripple effects through entire communities. What we've learned from years of public health response is that saving lives at this scale requires precision, speed, and coordination. And that can only happen when we have access to real-time trusted data, expertise to interpret and act on it. And that's why the Injury Center matters. Amongst all of their other functions, the Injury Center operates the most comprehensive data system on injuries and violence in the United States. And the systems don't just tell us how many people are dying, they tell us who is most at risk, where help is most needed, when and how crises are emerging, and what can be done to intervene early. This information is what empowers our state, our tribal, and local leaders to tailor their responses to the unique needs of their communities. So, talking specifically about overdose prevention, there was a slide about the Overdose Data to Action, or what we call the OD2A program. Through this program, the Injury Center awards $280 million across 90 health departments. And this funding is essential. It helps communities track overdoses, train peer navigators who guide individuals into treatment, enhance prescription drug monitoring programs, and conduct overdose fatality reviews. This level of coordinated data-driven action has been pivotal in states like Michigan and West Virginia, which, like Dr. Gracia mentioned, saw overdose death rates drop by more than 35% in the past year. That did not happen by accident. It happened because these states had access to the right data at the right time with the right support from CDC. If we consider suicide prevention, I just mentioned suicide takes nearly 50,000 American lives every year. And with that also comes a pretty staggering economic burden, over $500 billion with a B dollars annually. Yet for every death by suicide we prevent, we save not only a life, but an estimated $10.4 million in medical and societal costs. CDC really $23 million investment in suicide prevention is targeted, it's evidence-based, and strategic. It focuses on high-risk populations like youth, military personnel, rural communities, and middle-aged men, groups where we know suicide risk is disproportionately high. And again, it's the data that guides us. CDC National Syndromic Surveillance Program, and that enables public health professionals to detect increases in suicide attempts and suicidal thoughts in real time, which gives us the chance to intervene before tragedy occurs. This work is complementary to the work that SAMHSA does to ensure access to treatment and services during and after times of crises. I'll give you a quick example. In Tennessee, CDC supported efforts to establish real-time monitoring for emergency care visits related to suicide. If there's an above average number of visits in a rural area, alerts go out to a network of local partners who can take swift community-based action. Since implementing this system, Tennessee saw a nearly 9% decrease in suicide among rural populations, while the national rate in rural areas simultaneously increased by over 7%. These are the kinds of real-world outcomes that are only possible when we invest in federal expertise, science-based programs, and robust data infrastructure. So that's why we're deeply concerned about the potential loss of the CDC Injury Center, as has been proposed in the president's budget. There is no other agency that provides what the Injury Center does. No other agency collects and analyzes injury data across emergency departments, overdose deaths, and suicide attempts at the level of detail and speed that CDC does. And no other agency deploys scientists at the request of local governments to provide on-the-ground support when new drug threats or suicide clusters emerge. Without the Injury Center, communities will lose access to a range of resources. They will lose access to geospatial maps that help them pinpoint those overdose hotspots. They'll lose tools that track synthetic opioid trends, such as fentanyl and xylazine, and inform life-saving interventions. And they'll lose the ability to act quickly when suicides spike or new threats emerge. And maybe most devastatingly, they'll lose the data that show whether what we're doing is actually working or not. We simply cannot allow this to happen. Our progress, hard-won and fragile, depends on the infrastructure we've built, and the cost of inaction is far too high. I've heard many colleagues use the analogy in recent weeks that we will be flying blind without this data. I'm here to say that we won't just be flying blind. We'll be leaving thousands of preventable deaths on the table, and we'll be signaling to communities across the country that when it mattered most, we chose to look away. So today, with the release of the Pain in the Nation report, we are also issuing a call to protect and strengthen the backbone of our national prevention response, which is the CDC Injury Center, and the vital role that data and public health science play in saving lives. Thank you.
Thank you, Sharon. Appreciate your thoughts. Our final speaker for the panel today is Dr. Susan Consagra. Dr. Consagra is the Chief Medical Officer at the Association of State and Territorial Health Officials. She is formerly the State Health Officer in North Carolina. Dr. Consagra, please.
Great. Well, thank you, Ria. Thank you, Dr. Garcia, and the entire Trust for America's Health team for lifting up this really important issue today. As you've already heard, injuries are the leading cause of death for Americans in the first half of life. So this is not a small issue. It's not a distant issue. It's something that is a leading threat to our children, to our adolescents, to our hardworking families, and is ever present in our communities. And not only, as you've already heard, is it costing us $4 trillion every year in lost productivity in medical care, but it's costing us in priceless lives. Specifically, overdose is the leading cause of injury death among adults 18 to 44. And this crisis reached a tipping point back in 2017 when the president then declared it a public health emergency and said, we can be the generation that ends the opioid epidemic. And that vision is within reach, but only if we stay ahead of this evolving health threat. And there is hope. Again, you've already heard the good news around the data. CDC announced the largest single-year drop in overdose deaths on record. And according to that provisional data, deaths fell by 27% in 2024 compared to 2023. And that drop didn't happen by chance. It was the relentless work of healthcare providers, of community-based organizations, mental health providers, of our state and local health departments, and of course, the families impacted as well. So thousands of people are alive today because these people worked tirelessly. As you all know, when you walk into a provider's office, they work to treat you, the patient, to help support you, the patient. Well, public health does that at scale. Our state and local public health departments are working to protect entire communities by helping to build up systems, policies, and environments that stop illness and injury before they start. Public health departments have long served as leaders working across sectors and disciplines to respond to health threats like suicide and like alcohol and overdose related deaths. And they do this by identifying those emerging trends, by implementing life-saving programs and working with diverse partners from law enforcement to behavioral health care providers. So they are changing the trajectory of lives. I'm really proud of the work that we did in my home state of North Carolina. One example of how we've used federal funds and put them to work locally on innovative programs to prevent overdose is a peer support program that we implemented with our hospital association. We place those peer support specialists in emergency departments. Peer support specialists are those that have lived experience with substance use and help others in their recovery journey. They're highly trained. And through this program, these individuals connected with survivors of overdose that were in the emergency department, both at the bedside and after discharge. They were an ongoing source of support and created connections to naloxone, to treatment, and to recovery resources. And that's really important because data tells us through some of these data collection systems that were already mentioned, data tells us that when people come to the emergency department with overdose, they are much more likely to die in the next several years from overdose. And that is a terrifying fact. So over 18 months, this program reached over 5,000 individuals and prevented readmissions to the emergency department by over 30%. And that success was only possible because federal investment allowed innovative programs like this that created real impact on the ground for the communities. States across the country have invested in programs like this, including in post-overdose response teams, in naloxone distribution networks, in training providers and incorporating addiction treatment into practice. There is a myriad and a whole host of work that is happening across the country over the last decade and even as we speak now. I'm also really proud of the work that our state did to prevent suicide and support mental health through funding from Centers for Disease Control and through that Injury Prevention Center. We launched a program called Faith Leaders for Life. That was a really unique initiative that trained clergy across the state and equipped those faith leaders with the knowledge and skills they needed to support individuals at risk of suicide within their congregations and in their communities. Through this training, these trusted community leaders had the tools to speak about suicide, offer support, and connect people to help prevent the next tragedy. The faith leaders that were trained through this program, as just one example, reach over 20,000 congregants. And so this is another example of a federal investment in state and local programs that creates wide reach. And again, those have been built over the last decade with the help of that funding and through this concerted community action across a whole host of things, including overdose, including alcohol-related deaths, including suicide. Just to reiterate, 80% of CDC funding goes directly to state and local health departments and territorial health departments, and it's used by these departments to prevent suicide, overdose, and alcohol-related deaths, among many other causes of injury. And that's why the continued investment is important, because it translates to real work on the ground in your communities, and that work isn't done. As you've already heard, 80,000 people still died in 2024, despite the progress we've seen. That's 80,000 families shattered. That's 80,000 people that are not at the dinner table tonight. So this moment and this inflection point is really important. We're seeing signs of progress, but that progress is not universal and it's not guaranteed to continue. So if we don't continue to invest in these programs, we run the risk. Those community-driven public health strategies work, and we are seeing signs of the progress. So now is a time to double down, renew our investment and commitment in funding the programs that support the health and well-being of communities across the nation. So thank you so much for tuning in. Thank you for listening to this important issue and some of the work that is being done on the ground. And I will turn it back over to you, Ria.
Thank you, Dr. Consagra, and thanks to all our panelists. We're going to move to the Q&A portion of our program, but before we do so, I want to introduce two additional members of our panel. Dara Lieberman is the Director of Government Relations at TFAH, And Molly Warren is the Senior Policy Researcher and Analyst at TFAH and the lead author of the Pain in the Nation report. Okay, we're now ready for your questions. Please submit your questions using the Q&A tool on the platform. And while you're doing that, I will move to a few questions that have been submitted before this afternoon's program. Let's begin with a question that was submitted about the underlying drivers of substance misuse and suicide. The report talks a good deal about the role of these underlying drivers. I'm going to ask the panel to help identify what those drivers are and how they influence these rates of deaths and what can be done to address them. Dr. Gracia, can we start with you, please?
Sure. Thank you, Ria. To begin, you've heard from our panelists as well about the importance, for example, of having access to healthcare, having access to services. And that is certainly an important dimension when we talk about drivers of health. What we also know is that our health is not solely driven by what happens in the healthcare setting in terms of a clinic or hospital or emergency department, how much the conditions in which we live, work, and age really influence our health. And that is true as it relates to substance misuse and suicide. When we think about community conditions and the social and economic conditions that people face, whether that's, for example, experiencing an adverse childhood experience or other traumatic experience, whether early in life or across your lifespan, that can have impacts in terms of your mental health and well-being and increasing risk of suicide, increasing risk of substance misuse. It's also factors like economic and financial hardships. So many individuals and families who are struggling just to make ends meet, lack of employment opportunities, housing insecurity, food insecurity, that can create these stressors that really increase the potential risk for poor mental health outcomes, for increasing risk of substance use. And certainly the exposure with regards to what we are seeing now in trends in terms of trends in communities with the drug supply, as we've seen, for example, fentanyl, which has increased the lethality with regards to drugs that are in the drug supply and increased the risk of drug overdose. All of these factors can contribute to what we see as underlying factors and why it's so important when we speak about prevention that we're really getting at root causes, and also understand that when we talk about mental health and substance use, substance misuse, that this is not an individual failing, that this is not something that should be treated differently than how we treat physical health conditions, that it's critically important that we understand how mental health and substance use is part of our overall health and well-being.
Thank you, Dr. Gracia. Dr. Consagra, anything to add?
Yeah, sure. I'll add, in addition to the things that Dr. Gracia mentioned, which are all so important, the concept of adverse childhood experiences. We know based on lots of data that when children suffer traumatic events at an early age, that is an underlying risk factor for both mental health related issues down the road, as well as substance use. And so working to implement programs at an early age that support families, that support children, really important, because we know that some of these things are intergenerational, right? So if a child grows up in a home where they are suffering or seeing the effects of substance use, when that child grows up, that is increasing their risk factors for substance use as well, or again, mental health issues down the road. And so working to help support families as a whole, create those supportive environments, support resiliency, provide nurturing, caring, stable relationships is really important along young age to help support health across a myriad of things, including the issues we're talking about today.
Thank you. Sharon, anything you'd like to add about the underlying drivers?
I think just one, in addition to everything that Dr. Gracia and Dr. Consagra said, it's important to note that the risk factors for suicide and overdose often overlap and interact. So for example, mental health conditions can contribute to both suicidal ideation and substance use, which then increase the risk of overdose. Social isolation and lack of support can exacerbate mental health problems and substance use issues. I think when we think about addressing them, we really need to think about the expansion of community-based care strengthening those social supports, improving the economic opportunities, and reducing stigma around mental health, and just thinking about the interplay across all of those.
Thank you. And we have a submitted question from the Mountain State Spotlight, which is in West Virginia. The question is about that state's approach to overdose declines, which are declining, and Medicaid waivers. So the reporter is interested in the role that the Medicaid waiver may have played in the decline. The decline was more pronounced amongst white people in the state. That's true nationally as well. So what is the role of Medicaid generally and Medicaid waivers in helping to reduce numbers of overdose deaths? Susan, you want to start? Dr. Consagra, do you want to start?
Yeah, sure. I'll just say generally, we know Medicaid provides support for mental health resources and substance use resources. Again, just going back to an example from the state of North Carolina, which I'm, very familiar with living here. We worked on Medicaid expansion, and over 600,000 people were eligible for Medicaid in our state due to those expansion efforts. And many of those people were in need of mental health and substance use services that they were then able to get as they got this coverage. And so that, of course, is so important. While I don't know the specifics of the waiver request in West Virginia, I'll say, there have been innovative programs, including a waiver program that was implemented in North Carolina to help provide wraparound resources to support individuals, for example, including support with housing, support with transportation, support with food, and that was all done via the Medicaid program to provide holistic services back to individuals, because we know, again, what we do in the clinic is really important, but so much of health is determined by what happens outside of the clinic. So the more that we can create these comprehensive systems that support that entire well-being, whether that's through Medicaid, through what our state and local health departments and territorial health departments are doing within their communities, along with community-based organizations, the more we create that wider net, we know that we are having impact. So, certainly West Virginia is an example of this. And I know that there are some additional data points and stories within the report as well that speak to things that state and local territorial health departments have been doing, like post-overdose response teams, like naloxone distribution, like expansion of peer support, like expansion of diversion programs, so many things that, come together to make an impact that we are seeing now in our data.
I'll just add to Dr. Consagra's points and really appreciate, describing to what happened in the state of North Carolina, again, with regards to the importance of Medicaid, speaking about access to care and access to having access to coverage. Medicaid, as was stated, it's the largest single payer of mental health services nationally, and really providing those services. It's a lifeline for so many people who have mental health conditions, who have substance use, and it's critically important to being able to help promote mental health and well-being and access to care and treatment. I'll say in particular for the reporter who asked specifically about West Virginia, also just want to point out that in our report, we have an interview with the former mayor of Huntington, West Virginia, Mayor Williams, who spoke about his commitment and what he learned through his term as mayor with regards to addressing the drug overdose crisis and the importance of really working across sectors and engaging with community partners and taking a public health and prevention approach, including many of the things that Dr. Consagra spoke about, things like assuring the access to naloxone, doing the outreach and education, but making sure that those types of prevention programs and understanding who was being disproportionately impacting, using the data to really guide and direct those efforts, that those were some of the key strategies and approaches that they used during his tenure as mayor.
Thank you. Sharon, can I ask you to take the question and broaden it a bit? We know that 7 states had truly remarkable reductions in overdose deaths at the 35% level or better. Are there some unique factors amongst those 7 that are supporting this success, or what would you say was the story behind that storyline?
and we'd have to take each of those states individually. I think one of the things that I would flag, certainly with the CDC funding and more broadly across any of the states, is really this coordination aspect, right? So where we're doing really well across the board is getting much better data, which guides our decisions around, like what we were just talking about where communities could prioritize naloxone distribution, for example. But there's also this aspect of tailored interventions. Each state and each community has the opportunity to pull in the partners that are most ingrained in their communities, who can partner to help create these networks, so that we're not only identifying overdoses, but we're also getting people into treatment. We're working on stigma. We're working on tracking fentanyl and other threats or new substance trends. I think that's one of the things that we don't talk enough about, especially when we're talking about the role of the federal partners in this state and local landscape. You know, CDC has, right now, the Injury Center has access to laboratory equipment that monitors the drug supply, so that when a new drug is showing up in Maine, for example, they can alert Washington State, they can alert Oregon to be looking for this, so that as soon as it shows up there, they're able to respond and tailor their treatments appropriately. So it really does come down to resource allocation, to prioritization, to evaluating effectiveness, and this constant daily, hourly coordination across partners to ensure that we are creating the best systems to capture folks.
Thank you. Next question is about the tragically high rate of drug, alcohol, and suicide deaths within the American Indian and Alaska Native community. They have the highest rates of such deaths compared to other racial and ethnic groups. Why is this? What's the underlying factors of that story, and how should it be addressed? Dr. Gracia, can we start with you, please?
Sure. I think, it's indeed seeing these rates among the American Indian Alaska Native population is truly tragic. And as you've been hearing us describe with regards to some of the underlying factors, we talk about barriers in accessing health and healthcare, but also barriers that can exist in communities to promoting health and well-being, as well as the community conditions. And what we know in particular as it relates to American Indian and Alaska Native populations, there are also unique factors as we talk about trauma and intergenerational trauma, as Dr. Consagra spoke of, the historical trauma that tribal nations, for example, have experienced, and the subsequent disinvestment in tribal nations, that has left, many communities in Indian country, as well as Alaska Native and American Indian populations outside of Indian country that are in urban settings, with less resources and access to resources, higher rates where you see, for example, rates of unemployment and poverty, and other issues that really can contribute to poor mental health outcomes, as well as higher risk in terms of substance use. When we talk about as well what some of the opportunities are to be able to address this, it's something I heard Sharon say is really assuring that we're tailoring the programs and interventions to support the needs of communities. That's what makes, for example, working with tribal partners, with tribal nations, tribal health departments, other tribal organizations, so critically important to understand the unique needs of the population, and to be able to provide services and prevention programs that are culturally and appropriate to serve the needs of the community. When we spoke earlier about the suicide prevention program as an example out of CDC, there's a focused program specifically addressing the needs for tribes. This is what we mean when we talk about the importance of tailoring focused strategies that are proven strategies, and assuring that that type of investment and that workforce is sustained to be able to address what are some longstanding disparities that we see as it relates to substance use and suicide in these communities.
Thank you, Dr. Gracia. Other comments on the American Indian Alaska Native data?
Dr. Gracia hit the nail on the head. Historical trauma, geographic isolation, systematic disinvestment, these all really play a role. The thing just flag, when the layoffs happened in early April for HHS, one of the things that happened was that the administration sent certain senior leaders from HHS specifically to IHS without necessarily their request and without them having a grounding in tribal health. And so when we're talking about solutions to these disparities, we really want to be investing in native-led health initiatives, improving the infrastructure, integrating those traditional practices into our care models. And it's a disservice to our tribal partners to not be thoughtful about that.
Dr. Consagra, anything to add?
I think folks covered it well. And I think, one thing I would emphasize again for our tribal partners as well, for our local health departments that are doing work in these communities, the funding to do all of this is so important. And so again, 80% of the funding that comes federally goes to support these types of efforts locally in the community that are tailored to the needs of the community. And I just can't emphasize that enough. So thank you.
Thank you. Let's go to a different population group now, young people, teenagers, even preteens. What are some of the special considerations in ensuring mental health and wellness amongst young people and in bringing those rates down as well? Dr. Consagra, why don't we start with you?
Yeah, sure. So, I think there's been a number of interventions and again, local, state, territorial led work that really has been focused on youth. And some of that includes school-based work. So for example, ensuring availability of school-based mental health services, including making the availability of naloxone in schools, which we see more and more states doing and communities doing. Funding family-based interventions that support and train parents and caregivers in prevention skills and practices to be able to support their youth. So there's a lot of work that's happening. And again, a lot of this work is federally funded. Both SAMHSA and CDC both fund youth work that then locals, states help support on the ground. The data collection piece is really important too, because again, how do we know what is happening with our youth if we don't measure and understand the data and track those trends over time? So that is another really important function of our CDC Injury Prevention Center, as well as other data systems that we have across both CDC, SAMHSA, other federal partners that help design those tools, but then they are implemented at a local level to be able to collect and act on that data. So, specifically, those are a few of the things that we're seeing around youth that we know has been increasing and federal support has been increasing for. Again, those school-based models supporting that mental health, particularly for youth, which we know we've talked a lot about and certainly see across in the media the impact that the mental health system particularly has for our youth.
Next question about the 988 crisis line. It will celebrate its third anniversary this July. Talk about whether the ways in which the crisis hotline has helped save lives, and how is the funding sufficient, and how can it be made even more impactful? Sharon, you want to start?
Yes, I'm happy to start. So 988 crisis line has certainly improved access to immediate crisis support and diverted many people from emergency departments and law enforcement. It still needs sustainable funding to expand its workforce and to reduce wait times and to ensure follow-up care. But it really is effective because suicidal ideation comes and goes. It oftentimes is not a static feeling in somebody. And so what it does is it allows an outlet when somebody is having these suicidal thoughts. It lets them turn to something constructive, to interrupt and to take advantage of teachable moment is not the right phrase, but to take advantage of a moment where there's opportunity for intervention. I don't work as closely with 988 as perhaps Dr. Gracia or Dr. Consagra do. So I would love to hear their thoughts on this. But certainly the bottom line is that it has improved access to immediate support. And this is something that we not only want to maintain, but we want to grow.
Dr. Gracia, more on that?
Yeah, I'm happy to jump in. Thank you, Sharon. You know, since 988 was launched, indeed, we have seen just the overwhelming use in terms of 988. There have been more than 14 million chats, calls, texts to the 988 line by individuals who are in need of those types of crisis services. And we're seeing that volume continues to increase. And as Sharon noted, the improvements being made in terms of the wait times and connection to services. As we approach this third anniversary of the launch of the Lifeline, there are challenges though, and that starts with public awareness. There's still more that needs to be done to raise awareness of the Lifeline and assure that individuals understand the types of situations in which you can utilize the Lifeline. It's also about funding, as Sharon noted, that there are many states that haven't yet dedicated permanent funding to support the Lifeline, and needing to see that to be sustained and working in partnership with the federal government to assure that that service can be sustained in communities across the country. It's also a matter of just ensuring that as we think about the local centers, for example, where it's really important, for example, to be able to connect individuals locally to the crisis centers. We're also seeing, for example, reports of the staff turnover and the burnout that exists in these centers, and in large part because of some of the workforce shortages that exist. So the need is great. We have to continue to work to address that need, because as Sharon noted, this can be something that it comes and goes in terms of suicidal ideation, and seeing the volume and the numbers of people that are utilizing this this crisis intervention service through 988 really is a critical function that we need to continue to expand and enhance our investment in.
Dr. Consagra, you emphasized in your remarks, as did many of the panelists, the fact that 80% of CDC's budget goes to support programs at the state level, state localities, and other organizations. Can you give me some specific examples about the type of technical assistance and expertise that CDC provides to a state when something happens at the state level?
Sure. So, that happens in a number of ways. One, I will say, a really concrete way that technical support is provided is in the form of boots on the ground. So, for example, what they call an epi aid, where trained individuals from the CDC will actually come into communities and help support around a crisis response or around an emergency. We're seeing that in our country now. For example, CDC staff were in Texas around measles, but in the past, the Injury Center has also sent individuals to support states and locals in responses around injury, overdose, suicide, and those types of issues as well. So that's one really concrete way, again, local support on the ground in the form of people and experts. Second is by being the body that actually has the national picture. So, if we're doing something wonderful in this state, the ability to take that example and share that with other states, to take those lessons learned and replicate them and scale them to a national level is really important. And having an entity that's able to do that, to utilize the experts they have, to recognize that impact that perhaps is happening in a local community and translate that for other states is really important. And then the third piece I'll mention is, again, just going back to monitoring and understanding what's happening. How did we know we were in an overdose crisis these last 10 years? We knew that because there were very specifically designed tools that were created at a federal level, but then implemented locally to collect that data and then amass that back at a national level so we could see trends over time. And in particular, especially for the issue around overdose, we have seen continued evolution in the types of drugs entering the country in the illicit market. So, when somebody dies of an overdose, it takes toxicologists to understand what caused that death and what were the substances that led to that person's death. And that oftentimes requires those toxicologists to have expertise to recognize something that is completely novel, completely not seen before, and then share that with the rest of the country. So that, again, is a type of function that was provided, continues to be provided by the CDC, that technical expertise looking across at a national level. which is hard to do individually, state by state. So, lots of important expertise there in the data, providing that boots on the ground and helping create a national picture and national response.
And it's just that kind of on-the-ground assistance, expertise, and data collection that's at risk with these proposed budget cuts, correct?
Yeah, so, we have seen already some budget cuts hit state and local health departments that resulted in them. And it wasn't around necessarily issues here, but in other places that really went to focus in lab capacity on their ability to detect emerging health threats and respond to that health threat. So we've already seen some funding cuts there that have had direct impact, both in terms of layoffs that health departments have subsequently had to make, in terms of contracts that they've had to end, in terms of community partnerships that they've had to end. So yeah, some of these things have already happened. And of course, the risk is that we will see more down the road. And given that the public health system across our country is already underfunded at baseline, this provides great strain. And again, just really provides really will create direct impact to these programs, these services on the ground that support individuals in our communities.
I'd like to quickly add on. One of the things that's been proposed through the president's budget is for overdose functionality to move to the Administration for a Healthier America, AHA. And should that come to fruition, there are two things that I'll flag. One is that right now the total budget for AHA is equivalent to the CDC Injury Center budget for overdose alone. So there's really not a situation in which funding for overdose would not be reduced if that comes to fruition. The other, we've mentioned lab capacity a couple of times. Right now, CDC is the only federal agency working on overdose that has access to these functionalities. If overdose moves from CDC to AHA, we lose that functionality, and we lose that all of the things that Dr. Consagra was just mentioning are provided to us with that real-time understanding of what is in the drug supply and how can we respond in real time to minimize harms.
Thank you. We're approaching the end of our time this afternoon. I'd like to spend a few minutes by asking the panel to just each of you make a wrap-up remark. What is something you'd like to emphasize from today's program? Dr. Garcia, we'll start with you.
Thank you, Rhea. I will say for decades, we have been watching this crisis in terms of mental health, substance use, drug overdose, suicide increasing in our country. And today we shared promising news with regards to declines that we've seen in 2023, as well as this unprecedented one-year decline in 2024. Now is not the time to turn back on that progress. It's the time to recommit and further these investments to this work. We know what works. We know how to prevent these deaths, these tragic deaths that are impacting hundreds of thousands of lives each year. And so by investing in and sustaining our investment in primary prevention and mental health and substance use, we can truly save lives, promote mental health and well-being for our country. Now is the time to further commit to that, to assure that everyone has the opportunity to be as healthy as possible.
Thank you, Dr. Garcia. Dr. Consagra.
Hey, yeah, I will just double down on the message that, funding to support public health is so important. State, territorial, local health departments do such great work on the ground. They're doing work that creates impact, that is saving lives, that is preventing deaths, and they are doing this with the support of resources at all levels of government, but particularly federal investment, we know has been so important, given 80% of that goes right back down to local communities. So, want to emphasize that, for our congressional leaders, really important that they look at the trade-offs involved on funding changes and evaluating those against what they're seeing in their communities as they make those decisions. That work is important. And as Dr. Garcia already mentioned, we're seeing progress. We're seeing change in the metrics. We're seeing change in the numbers. So, now is such an inflection point and such a critical time to relook at that, to double down, to help support these trends continue and to continue to see this positive news in our communities. So I'll leave it at that. Thank you.
Thank you. And Sharon Gilmartin.
In addition to everything that my colleagues have already said, I'll just reiterate that behind every data point that we've talked about today, behind every data point in the Pain in the Nation report is a person. That's a life that can be saved with the right resources, the right strategy, and timely action. And we've seen what's possible when prevention is grounded in science and powered by data and supported by federal leadership. So this is amazing progress, but it is at risk. And specifically to the CDC Injury Center, it's not just a data hub, it's the backbone of our nation's ability to respond swiftly and effectively to overdose and suicide crises, amongst others. So if we lose that infrastructure, we're losing time, we're losing coordination. And what we certainly don't want to happen is that ultimately we will lose lives. So our communities really deserve better. They deserve sustained support. They deserve clear-eyed leadership and a commitment to prevention that doesn't waver when progress is finally within reach. Thank you. I'll end there.
Thank you. Thank you to our panelists. Thank you to media for joining us today. We will be sending out the press kit and any other materials that we've discussed during the briefing shortly. So you'll get that this afternoon. If you have additional questions that we didn't get to that you'd like us to respond to, or if you'd like to speak to a member of our panel one-on-one sometime this afternoon, please email tifa@burness.com. That's the same email you used for your RSVP, TFAH, TFAH @burness.com. And we'll get back to you quickly and we'll set up an interview for you this afternoon or whenever it's convenient for both parties. Thanks again for joining the briefing, and thanks to our panel. Good afternoon.